Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hi, everyone. Welcome. My name is Dr. Jill Jin, internist and senior physician advisor here at the AMA. On today's podcast episode, I'm joined by Dr. Gaurava Agarwal, Vice President and Chief Wellness Executive at Northwestern Medicine, also a psychiatrist who specializes in occupational and organizational psychiatry with an emphasis on workplace mental health. Our topic of discussion today is an initiative that he was involved in called Frontline Connect, Mental Health Care for the Healthcare Workforce. This is an initiative by the Center for Workplace Mental Health, which is a program of the American Psychiatric Association Foundation that provides leaders of health systems with high-impact resources and strategies to improve access to mental health services for the healthcare workforce. Thank you so much for being here, Dr. Agarwal.
Thanks for having me, Dr. Jin.
So you've been on our podcast before, but could you share a little bit more with our listeners about yourself and your background and how you came to be involved with this Frontline Connect initiative?
I'm happy to. As you mentioned, I'm a psychiatrist. I'm a specialized psychiatrist that focuses in on workplace mental health, how organizations and workers can both reach their optimum potential. As a part of that work, historically, I took care of healthcare professionals who had become what we call impaired, who were no longer able to work due to mental health issues, substance abuse, depression, et cetera. And we would help rehabilitate them so that they could get back to work and go enjoy the career that they've obviously worked so hard to be a part of. Through that work, really came to understand the role of prevention and wanted to be a part of making sure that we could improve the environments that oftentimes my patients would tell me contributed to ultimately the stress and depression that I was actually seeing them for. And so I said, hey, is there something we can do upstream that would help them hopefully never need to see me? Because obviously that's the best case scenario for everyone involved. That journey led me to learn about the Center for Workplace Mental Health, which is one of the leading organizations that really focuses in on the impact of work on mental health and the role that mental health plays on us as workers. I'm a part of their advisory council and have been a part of that council for several years. And as they received a grant from the Brave of Heart Fund to advance resources for mental health, they asked me to assist in their work as a well-being advisor and consultant. And I had the great privilege to be on this journey with them over the last couple of years to put together the Frontline Connect toolkit that we're really, really proud of.
Excellent. Yes, and we will discuss that toolkit in depth. First, just to kind of set the stage a little bit, you've mentioned mental health quite a bit and mental health conditions among, the healthcare workforce as being a fairly long time problem that's been in existence. And of course, here with AMA Steps Forward, we focus a lot on professional burnout in general, especially in light of the COVID pandemic, which really exacerbated things. So can you further, define a little bit more your focus in terms of the mental health conditions as opposed to professional burnout as an entity and how you kind of chose that focus specifically?
Yeah, and I appreciate you asking the question because I do think through the COVID pandemic, sometimes we've ended up using these words interchangeably. And I do think it's really important that people recognize that we're really talking about two separate things. As I began my work in wellness, the truth is, as a psychiatrist, I assumed, most people would pigeonhole me or sort of think, okay, he's going to come in here and he's going to be talking about depression, focusing in on serious mental illness or suicide, et cetera. And so in some ways, I sort of overcorrected and was really trying to make sure that people understood that I'm here because I want to fix the workplaces, the organizations, the systems that contributed to the high rates of burnout that we see in healthcare professions. And that was really where our focus was, exactly the same focus you have at the AMA, the focus that the National Academy of Medicine has brought to this issue is, hey, this is a systems problem. This is not a problem of the individual. We need to fix the systems, and therefore we will fix burnout. And I still wholeheartedly agree with that and appreciate the work of your organization and other organizations in providing us solutions to that issue. What happened, I think, is through the pandemic, I was beginning to see people say, hey, you know what? I think that person's struggling. They must be burned out. Therefore, they need X. When we would dig down a little bit deeper, it was clear to me that we were potentially prescribing, quote unquote, the wrong treatment. Is this person was actually facing post-traumatic stress disorder. This person was actually having anxiety, significant mood disorders. We need to make sure that they're getting the appropriate treatment, not telling them that they have burnout, and then not getting them the high quality mental health care that they deserved and needed. In my world of occupational psychiatry, we have frameworks. And in that framework, we talk about primary prevention, which is fixing the systems, fixing the workflows, as you all have talked about extensively around burnout. There's secondary prevention, which is how do we help people that are experiencing distress? And then there's tertiary prevention. How do we make sure that people that their distress has progressed to mental health conditions, illness, and disease have what they need to recover and get healthy? And because this project sat in the Center for Workplace Mental Health, centered in the American Psychiatric Association Foundation, our expertise lies in those mental health conditions. And so we wanted this toolkit to really hone in on this issue of if someone's experiencing distress, what resources can healthcare systems provide to mitigate that distress so it doesn't progress to that third stage? And if folks are in that third stage, what resources do we owe our healthcare workforce so that they can recover as quickly as possible? And that those last two places is where we felt our lane was and where we could add value.
Got it. I really appreciate you outlining it like that, because it has been something that's been on my mind, at least, particularly as we're kind of really emerging from COVID. And it's not just a wide state of overwork and burnout for everyone, but it's really these, like you said, these different levels of prevention. And that's the first time I kind of heard it framed in that way, this primary, secondary, and tertiary, all of which are equally important. But I think that's true to some extent, what you say, where we've kind of sometimes swung too far. The pendulum has swung too far towards the primary prevention.
Sometimes people were well-meaning in this, right? They said, oh, let's call it, you're probably burned out. Seeking treatment for burnout is less stigmatizing than seeking treatment for depression or PTSD or something else. And so I understand why we did it, but I do think it is important to make sure we know what we are dealing with. You and I both have been taught in our training diagnosis before treatment. And so if we misdiagnose something, the chances that we treat it right, to me, are far lower. And so I do think to your point, it is really important that we make sure that we're clear about what someone needs and what someone is dealing with.
Yeah, so true. Well said. Okay, so let's get to the toolkit itself, the Frontline Connect toolkit. So it's essentially about sharing tangible steps that healthcare leaders and organizations can take to improve the mental health of the workforce. So can you walk us through some of those key steps?
Yeah, I think what I would just add to that is it's not just what steps they can take. Our goal with this toolkit was highlighting healthcare systems where they have actually taken these steps. They've actually implemented these programs already. Because my favorite thing about the AMA Steps Forward is you all are not theoretically talking about things that are happening. You're talking about real programs that have already been done, which to someone like me pushes me from a positive peer pressure sort of way to say, no excuses. This other system has done it. So you can't tell me it can't be done. It's already being done somewhere else. We try to follow your lead in that sense of finding, hey, what are sort of the innovations? What are sort of the programs, resources that healthcare systems around the country have already implemented? And what sort of results are they achieving? And we organized the toolkit in the same sort of primary, secondary, tertiary, focusing in on that secondary and tertiary prevention. Which programs are good programs to help folks in distress? So things like EAPs, employee assistance programs, things like coaching, peer support, and then looking at that tertiary care, understanding how folks have implemented either internal employee assistance programs, external employee assistance programs, how people are using the physician health programs, PHPs they're called, and really highlighting that when we send folks for that tertiary level of care, who are we sending them to? are there ways to make sure that the therapists and psychiatrists that are seeing our healthcare workers understand the culture of healthcare so that when they're treating these folks, they can be mindful of the work that we do. I think one of the examples that our folks in that toolkit session gave was, if you're talking to a clinician, a physician, and you say, hey, why don't you take an hour for lunch? Well, you're going to lose credibility with that clinician because that's not a thing, right? We're not going to be able to, that's not a solution that's valid. And it makes somebody feel like, hey, you don't understand what I'm dealing with. So having that cultural competency can be very important. So those types of interventions, I think, were what we tried to highlight.
Got it. So it sounds like the PHP programs in particular is kind of where you, earlier in your career, how you got into this field. Many physicians have probably heard of this, but just don't know the details about it or how to get connected, how to get referred, or, again, who are they going to be talking to if they are referred? Can you expand on that, provide some more details?
Sure. These programs are available to other healthcare clinicians increasingly, nurse practitioners, APNs, nurses, et cetera. And so I want to be clear about that. They came about because, again, this issue of stigma. If someone can't seek care early, then they're going to get worse. And now we're going to be seeing more severe symptoms of illness that can potentially be impairing and certainly potentially pose a risk to patient safety. So they said, well, how can we give physicians and other clinicians the sense of security that you can seek help early without fear of issues with the medical board? And so these programs were created to be able to get treatment for mental health issues without having to report to the board. Almost every state has one. And so what I tell people usually is if you just Google physician health program or PHP, Illinois in our case, they'll take you to your state program. And these state programs are designed to provide a source for you or, frankly, a family member who's concerned about you to reach out and say, hey, what are the good resources in our area, in our state, that can provide mental health care? They can usually do an initial evaluation to get a better sense of what your needs are, what may be useful to you, what may be going on. After treatment, you would go back and register with the physician health program. They can do much of the monitoring and sort of serve as somebody who can vouch for you, be your advocate as you re-enter the workplace or re-enter a healthcare system to say, hey, this person's doing everything they're supposed to be doing to maintain their health and they are safe to practice. And that serves a major role in the excellent outcomes that the physician health programs have over the long term because of that accountability and monitoring, in my view.
Yeah. And as you mentioned, so this is completely confidential. It won't affect your ability to practice or re-credentialing or anything.
Correct. That's the purpose of them, is to be separate from the medical board reporting.
And you mentioned EAP programs as well, which I think are sometimes also something that's a little bit dismissed in the burnout world, at least that I'm in. Like we're always telling organizations we need more than just an EAP program. But what is it actually, in your view, an ideal EAP program? Who should it be helping and what should it be providing?
The initial fork was twofold: an internal EAP, whereas the EAP is run by folks within a healthcare system, and then external EAPs where there's sort of a third-party vendor. And so that difference right off the bat can be a big deal. And so the internal EAP program that we highlighted was out of Oregon. It's really a best practice program that's been around for quite a while, and it provides free mental health care for their trainees, for their physicians on site, really by people that understand not only the healthcare culture, but certainly the local culture as well, because it is an internal EAP program. I think the other thing that they do that's really innovative is, a lot of times this work relies on someone reaching out for help. The interesting thing about an internal EAP is they become embedded in the culture. They can do proactive outreach. They can come to your department meeting. They can become a familiar face. You can decrease that sort of burden, that hurdle to reach out help when someone, hey, I know that person. They seem like a normal person. They seem friendly. I'm happy to go talk to that person and share a little bit about what I'm struggling with. And their utilization numbers, as they report in our toolkit, are totally different than the common conceptions of low utilization for a our healthcare professionals, especially physicians, when it comes to EAP. The external EAP program that we highlight in the toolkit is from an EAP that is specialized for healthcare professionals. And particularly, they do a great job of highlighting the difference between distress and that third bucket. And so through their EAP, they provide coaching from peers. So the coaches are nurses or physicians that can provide the coaching to other nurses and physicians at your healthcare system. So again, you have someone who is less stigmatized, because they're coaches, and this is not for mental health issues, and so you can address that distress level. And B, you have someone who understands your field because they're obviously in a similar job family as you. And sometimes I actually find it's really nice that it is actually usually obviously somebody from a different system than you. And so sometimes you can sort of reality check, is this just how we do things, or is this how it is everywhere? Or is there something we could be doing that's better? And so it's nice to have this sort of person that you can talk to that gets your field, but is not in your actual healthcare system. And again, this is to me an example of not just your generic offerings that many EAPs may have, but even their talks, their online materials are just going to be much more tailored to the healthcare world rather than, broadly speaking about stress generally that may affect somebody from a totally different industry than us. And while that I still think can be very important, you can imagine it may not land as well as somebody who's talking about the types of stress we deal with on a day-to-day basis.
Yeah, exactly. I do think that is a key point in terms of, our professional distress is obviously going to be very different from that of a lawyer. And so I think that's a great key point. Can you walk us through the process, I guess, of implementation? One of those things that, a lot of people look at this and will read the toolkit and say, these are great ideas, but how do I actually get it done?
Yeah, absolutely. The change management and the implementations is where all the secret sauce is. The first step of change management is just assessing of change readiness, right? And for every institution, you'll have to sort of begin there and say, hey, what are we ready for? Is the timing right? Obviously we're post-pandemic, but the memory is fresh and we know why this matters. And I do think for the leaders listening, I hope you will take this opportunity to implement some of these solutions. To your broader question, again, each initiative has its own change management process and needs. But broadly speaking, I think understanding who the stakeholders are the first game. I think if I look back at the errors I made, I asked the wrong people. It wasn't just a timing issue. I thought it was a certain group of people that I needed to make this change when it was really a different group of people. Understanding who are the stakeholders that you would need to get involved and be early adopters, I think is super critical. I think then you want to make sure you have a clear case for what the gap is. I used that word earlier. Leaders need to sort of see things in context. And part of the reason I harp on that primary, secondary, and tertiary is it does make it clear is, hey, we think we're really doing a pretty good job in primary, but then you can show them, hey, but here in this distress area, what is somebody supposed to do? So yes, we have good stuff for people that are having a mental health condition, and we have psychiatrists, we have good health insurance, we have employee assistance programs, we're doing stuff in the workflows, primary prevention. But what is the doctor that's burnt out supposed to do? Are you supposed to tell them to wait for the system to get better? Because that's not good enough. Do we have coaching available? Do we have peer support available in that middle zone? And so then people can't say, hey, I think we're doing okay. We don't need to worry about it. You've clearly identified where the need is. And I think that really mobilizes at least our leaders. And I think most leaders, we can really make the case for what the need is and why we don't currently provide it.
Anything else that you wanted to highlight from the toolkit in particular?
I think one thing that didn't probably fit neatly into those distress and tertiary prevention buckets that we've sort of alluded to, but I really just want to emphasize is there's still this issue of stigma and this issue of very real concerns about our licensure and credentialing. And so I want to just double click on the toolkit where we did speak to the Dr. Lorna Breen Foundation, which has been doing amazing work on providing a very actionable toolkit that both at the state level and at the local level in terms of our own personal hospital and healthcare systems. How do we change that licensure and credentialing language so that, any of these resources are actually going to be used, right? Again, if we don't make it safe to use this, you can build it, but they actually won't come. And so remembering that first step of being able to change these languages that have historically been at least one of the identified reasons by healthcare professionals not to use the other things within this toolkit, you have to make sure that we do some of those first steps first. And those changes can be great momentum builders for some of the other things on the toolkit as people say, hey, you know what, we really can make change. And that wasn't so hard. We can get this done. And if we can get this done, what else can we get done? And that's what I really love about that particular segment in the toolkit.
Yes, thank you for highlighting that. I think that is a perfect example of something that's low-hanging fruit, I guess. That's at the organizational level. That's a critical first step, that removing that barrier for physicians and other healthcare workers. Thank you so much for joining us today, Dr. Agarwal.
Thank you so much.
As always, listeners can find the resources mentioned in today's episode in the episode description.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.